services. Our chaplains are coming, all the different units. The emergency room has not been present in our, is there anybody here from the emergency room? Come to our palliative care committee. They have their own way of dealing with death because they deal with it all the time. Anita and their nurse manager are very good at educating and supporting all that goes on in the emergency room. I would love to learn more from them. But again, I'm not faulting them, but we really should, throughout the whole hospital, be on the same page with how we're treating our patients that are dying. Different floors have different issues. Primarily on the med-surg floors, it's comfort care. It's just comfort care, making those final days and hours good for the patient and their family. In the TCU, they have a unique area where a lot of times they have sick patients, chronically ill patients, maybe trached and pegged, and they're already DNR, DNIs, but they're not comfort care yet. So they're in this gray area of they start to get sick, their blood pressure is 80/40, they call an RRT, are we going to go to the ICU? No, we don't want to take them there because they're too sick. So there's a lot of what are we doing with this patient, and a family meeting hasn't been set yet. So this is an area that on TCU, nurses and physicians need to really collaborate and get a little more clearer where we are with our DNR, DNI patients. They just have a lot sicker patients where these issues are much more acute. In the ICUs, we're dealing with, well, we've already gotten to the part where we are on advanced life support, whether the patient wanted it or not. Now the family is speaking for them. They are on advanced life support, and we really don't see that there's a cure here, and we really do see that the patient may not make it out of the ICU. And having to come to terms with the family on accepting that the end is here is very, very difficult. And it takes days, weeks, months sometimes to finally get to that place with the family that we do need to let the patient go and withdraw support. So that's a whole nother realm and of an area for the ICUs, which we've tried to come up with solutions for that also. So we discussed tangible ways to make final days to hours of patients dignified, comfortable, and memorable. We've talked about all this. We support education of LNEC and palliative care for all patients and staff. We're implementing When Death is Near. It is an informational pamphlet for families about how to say goodbye in the final hours and the signs and symptoms of death. We haven't quite gotten it out to the families yet, but we're coming up with it. Our chaplains are starting to organize a hospital remembrance service. The goal, we tried to do it for this year, it didn't quite work out. The goal is for November 2012, where we would invite all families back who've had deaths in the hospital. We'd invite all staff who've been affected by deaths to either come in and light a candle, lay a carnation, share if they wanted a mic, maybe something where we're coming in and out. Any details are yet to be worked out. So moving on to the ICU experience. As stated, with the issues that we come up with, trying to come up with a communication tool or education so that nurses and